morning, everyone. This is Shalia with Healthcare Authority, and I will let Heather introduce herself.
Good morning, this is Heather with the Healthcare Authority, and I'm having some technical difficulties today, so I'm going to keep my camera off in hopes I don't get kicked out of the Zoom.
Sounds good. All right. We do want to let you know that this webinar is being recorded, and a copy of the recording will be sent out in about a week or two to everyone who registered for the webinar. We have a great agenda today, so we will definitely try to answer as many questions as we can. Please enter any questions you may have during the webinar in the Q&A box, and we will go over those and read those at the end of the presentation. And if there are questions that we are not able to get to during the webinar, we will send out a FAQ with the recording as well. And I hope everyone is able to hear me. Wonderful. Again, welcome. We are glad for everyone joining us today. We have some wonderful presentations that we have scheduled for today. Vaccine recommendations during pregnancy through the infant's first year, presented by Kate Cranfeld and Christine Raleigh. We will then do program updates and reminders, any questions that you may have, and then just a wrap up. So let's welcome our presenters. We are very excited to have them today. So we have Kate Cranfeld. She is a public health nurse at Tacoma Pierce County Health Department and co-chair of the Pierce County Immunization Coalition. She received her Bachelor of Nursing degree from Washington State University and Master of Nursing in Community Health from University of Washington. She focuses on immunization promotion across the lifespan and supporting local providers with communicable disease questions. And we also have Christine Raleigh today. She is a registered nurse and program manager at Mary Bridge Immunization Clinic. She received her bachelor's from the University of Pennsylvania and has worked for Mary Bridge as a pediatric nurse since 2015. As the sole provider at the immunization clinic, she provides thousands of vaccines each year to children in Pierce County. She also works with the health department and local schools to increase access to vaccines and translate immunization records. And we are so happy to have them today, and I will go ahead and turn it over to them. And I believe Kate is going to be starting first. So I will stop sharing and then you should be able to share.
Hi, everyone. Yes, just give me a moment and I will share my screen. Okay. All right. So thank you so much for having me today. I'm excited to talk to you all about vaccine recommendations during pregnancy. And again, Kate Cranfield, and I am a public health nurse in Tacoma, Washington. So today, in my portion of the presentation, we're going to go through why vaccines are important during pregnancy, which vaccines are important during pregnancy, and learning practical tips for talking about vaccines. So first, I do want to start with why. And when you are pregnant, you are at higher risk for certain infections. So, the reason is, a couple reasons are suppressed immune system. So, you know, the body is obviously going through a lot of changes when you're pregnant, and what some of those changes are involve your immune system. And this is because your body, doesn't want to recognize your fetus as a foreign entity. It's wants to continue growing, developing your placenta. So the immune system is less efficient at this time, leaving people more susceptible to infections, especially like flu and COVID-19. And then additionally, you do have an increased fluid volume during pregnancy. So you need more blood to increase your oxygen supply to your placenta and your growing fetus. But this does add stress to the heart and lungs, leaving you susceptible to more complications from, a respiratory infection compared to a non-pregnant person. And also, when you think about some diseases like varicella and rubella, we obviously, most people get these vaccines when they're in childhood. Christine will go over those recommendations. But so most people are immune, but if you aren't and you do get these infections, they can cause serious birth defects, particularly chickenpox and rubella. So vaccines are, extra important during pregnancy to protect that person as they are, growing a human. What's also really cool about vaccines during pregnancy is that they also can protect the baby after they're born. So this is through passive antibody transfer. The pregnant person's body is, making those antibodies after receiving a vaccine and passing them on to the baby. And after they're born, they do benefit from that protection for a bit until they're old enough to get vaccinated. So I do think that is one, really amazing thing about vaccines during pregnancy that I'm excited to talk about. One general rule is to avoid live virus vaccines during pregnancy. And this is because there is a theoretical risk to the fetus. So before we jump into the specific vaccine recommendations, I do want to talk about vaccine safety. So I'm going to talk just generally, vaccines are some of the safest medications out on the market. There is a higher burden of safety because they are given to people who are well, and we don't want them to cause any harm. So there are a lot of systems in place to monitor that safety. So of course, there's the trials before the vaccines are on the market that FDA and the CDC will review, and before they, give approval and recommendations to go ahead and give. But the safety systems continue on afterwards as well. So a lot of people have probably heard of the VAERS system, or the Vaccine Adverse Event Reporting System. And this is a very general system. Anybody can enter information into it, and basically it just says a vaccine was given and an event happened after. There is no causation proved or attempted to be proven by VAERS. It's just a system that people can enter into, healthcare providers, family members, anybody can enter. And it, kind of, if there are patterns that are seen, then CDC can look into if there is any causation or correlation between a vaccine and an adverse event. Some of the other systems that exist that maybe you haven't heard of as much are the Vaccine Safety Data Link, which is 9 healthcare organizations that monitor vaccine safety, along with the CDC. So kind of looking more specifically about, cases and trying to determine that causation. There's also the Clinical Immunization Safety Assessment Project, which provides medical consult on individual cases. So once again, looking into more of that causation. And then with the COVID-19, people probably heard about the V-Safe program. So that is being used more often. And there is actually a pregnancy registry associated with the V-Safe. And additionally, there's the birth defects study to evaluate pregnancy exposures. So this is not just for vaccines, it is a system to understand the causes of certain birth defects. So all of these systems kind of come into play to ensure safety of vaccines as, across time. And we know, we do know that they work, and they are quite sensitive. And, there are some, rare adverse events that can only be seen after millions of doses are given. And like we saw with the Johnson & Johnson COVID vaccine, the thrombosis with thrombocytopenia, the TTS, that was a very, very rare but serious adverse event. And our safety systems did signal that. And, it did cause a pause in giving that vaccine and, looking into more research. So we do know that these systems work and are very sensitive, because not everything is going to be picked up in the trials before a vaccine is on the market. And additionally, I did include some links. So when the slides are sent out, there are many studies done on these vaccines during pregnancy. So not just looking at the data from the general population, it's looking at giving these vaccines to people who are pregnant. So let's jump into which vaccines are recommended. So we will start with the Tdap, or tetanus, diphtheria, and pertussis. This is given between 27 and 36 weeks gestation, and it is recommended every pregnancy. So this vaccine is focused on protecting the baby from pertussis, or whooping cough, which, if you have seen a baby or cared for a baby, a small infant that has had whooping cough, it is very, very scary and can be very serious for babies in particular. So we do know that this vaccine is really effective, especially, during the first 2 months of life, which is important because that's too young for a baby to receive their own vaccine. And it's effective during the first year of life as well, and very protective against hospitalization and pertussis-related death. And this method of ensuring the baby has some antibodies against whooping cough is more effective than, a cocooning method, which people may have heard of, where, everybody that's around the baby gets an updated Tdap. Definitely the pregnant person getting the Tdap during pregnancy is more effective in protecting that infant from whooping cough. All right, and next we'll talk about flu vaccine. So of course, the recommendation for flu is we give it, every year. Generally, we like to give it before, the end of October to protect people from flu-related complications. As we know from earlier, pregnant people are at higher risk for a severe case of influenza due to that high increased fluid volume. So important for the pregnant person to get the vaccine. And additionally, this vaccine passes on protection to the baby as well after they're born, which again is very important because babies can't receive their first flu vaccine until they are 6 months. So what's important here is using the inactivated vaccine, or the injectable form of the vaccine, and not the pregnant person should not receive the nasal spray, because that is a live virus vaccine. So, and it does, receiving the flu vaccine during pregnancy does reduce the risk of hospitalization for a pregnant person by 40%, and for babies by 72%. So again, we know that, these vaccines are effective. Next, we'll talk about COVID-19 vaccine. So this vaccine is safe to give anytime during pregnancy. It can be given before, during, after pregnancy. We know that evidence continues to show that there's no association with any fertility issues in men or in women. And as far as the schedule goes, it's basically ensuring that that pregnant person is up to date on their COVID-19 vaccine. So right now, that means that they've gotten the one dose of the updated 2023-2024 COVID vaccine. And again, like the flu vaccine, this protects the pregnant person from serious complications, and it does protect the baby after birth as well. Babies can't receive their first dose of COVID-19 vaccine until 6 months. So, and COVID-19 infection during pregnancy has been shown to increase the risk of preterm birth or stillbirth, and the vaccine is associated with a decrease in stillbirth rates. So a super important vaccine to get during pregnancy, or ensure you're up to date on it during pregnancy. And going to move on to the newest vaccine that we have. I'm sure you've been seeing lots of webinars and lots of information on the different RSV prevention products as they are new this year, which is really great because RSV is one of the leading causes of hospitalization in infants, and we now have 2 ways to protect babies from RSV. So I'm going to talk about the Abrysvo vaccine, which is given during pregnancy. There's also the Beyfortus or nirsevimab monoclonal antibody injection that can be given to newborns that I'm sure Christine will be touching on. So the Abrysvo RSV vaccine was just approved by FDA and CDC earlier this fall. CDC recommends 1 dose for people between 32 and 36 weeks of pregnancy during RSV season, and that's generally defined as September through January. Right now, there's no recommendation for additional doses in subsequent pregnancies, but I'm sure that studies are ongoing for that. So the vaccine during the trials was shown to reduce the baby's risk of hospitalization by 57% if they were born at least 2 weeks after the pregnant person received their vaccine. So if the baby is born less than 2 weeks after that vaccine, it would be recommended that they get the nirsevimab. Otherwise, it's a one or the other type thing. So the common side effects are injection site pain, headache, muscle pain, nausea, kind of the normal, reactions, immune responses you see after receiving other vaccines. So additional studies are underway on some rare side effects that were not statistically significant, but they were slightly higher in the vaccine group compared to the placebo group. So they are looking into them and doing additional studies. So one of those is preterm birth. A small increase during the trial, again, unrelated or unclear if it's related to the vaccine. They need more information on this. And that is the rationale for giving it at 32 to 36 weeks, because in the trial, I believe that they were studying it between 24 to 36 weeks. So it is given later in the pregnancy. And then with preeclampsia as well, a slightly higher increase in the vaccine group compared to the placebo group. So additional studies are underway. And I also want to touch on hepatitis B, just because I know that hepatitis B vaccine is, one of the first vaccines that a baby is likely going to receive after they are born. And it's important during pregnancy, because if a baby is born to a person with hepatitis B infection, they need post-exposure prophylaxis after birth. And this is because 40% of babies born to moms with a hepatitis B infection will develop a chronic hepatitis B infection. And that is avoidable with the post-exposure prophylaxis. So national guidelines include universal screening of pregnant people during each pregnancy. And if a pregnant person is not immune, there are hepatitis B products that that are safe to receive during pregnancy. And they should be counseled on additional methods to prevent hepatitis B. Of note, hepatitis B vaccine, if it is given during pregnancy, those antibodies do not pass on to the baby. So they would need, their birth dose and the hepatitis B schedule as any other baby would. Vaccines and breastfeeding. So most vaccines are safe to use while breastfeeding. There are two contraindications, which is one of the Mpox vaccines, ACAM 2000, which is not the one that we have been using here during the Mpox outbreaks, and yellow fever vaccines. So neither live nor inactivated vaccines showed a risk to the breastfeeding person or the baby. And then most of the live virus in vaccine is not excreted in the milk. And this is important because MMR is a live virus vaccine, so it's not recommended during pregnancy. But if a person does not have immunity, it can be given after the baby is born to provide that protection against measles, mumps, and rubella, which would be especially important, for future pregnancies, as rubella is one of those viruses that can cause birth defects. So now that we've gone over those recommendations, how many people are getting these vaccines during pregnancy? As you can see, the numbers are not super high. So we know that there is a lot of work to be done. So in 2022, almost half of the people received flu vaccine and Tdap vaccine. Fewer received both. And then as we look across, racial groups, we see that things are not equal. So pregnant people who are white have higher rates of Tdap vaccine than Hispanic and Black pregnant people. And we see this trend continue with both flu and COVID-19. In COVID-19, we do see the overall rate of vaccine or being up to date as lower than non-pregnant. So we know that there is a lot of work to be done around increasing our vaccination rates during pregnancy, keeping pregnant people safe and their babies safe from these infections after birth. And we know that the programming should focus on Hispanic and Black pregnant people especially, and building trust in vaccines and access to vaccines in those groups. So a little bit, let's jump into the barriers of getting a vaccine. So this slide is by no means all-inclusive. We know that vaccine hesitancy, for one, has a variety of causes. And again, this list is not at all inclusive. It's definitely one of those things that you need to have a, open-ended conversation with a person about if they do have, questions, concerns, hesitancy around vaccines, finding, their specific reasons. Some more common reasons that we see are, historical trauma around vaccines or around the medical system. We also, know that safety, people have safety concerns, and there's also a lot of misinformation out there and disinformation. And especially during pregnancy, especially if it's your first pregnancy, you're getting a lot of different information. You're, getting articles and, social media things popping up, and you're on message boards, and the people are volunteering their opinions about different things. So it is important to kind of break through that noise. So we know that a strong provider recommendation for vaccines is one of the most important, pieces of whether or not a person's going to choose to get vaccinated. And I think especially with all of the, misinformation and different opinions out there, having, a trusted source, as, your healthcare provider, be able to share accurate information on vaccines is really crucial. We also know if people don't have access to prenatal care, they are likely not accessing these vaccines or information about them. And I just wanted to show this slide to show that vaccine hesitancy is definitely a spectrum. It's not an all or nothing. Just because somebody refuses one vaccine doesn't mean they would refuse another vaccine. So it is really important to have conversations. And I had mentioned a couple slides ago that healthcare provider recommendation is extremely important. And so I just wanted to show this slide, a couple slides that echo that sentiment, where a study was done and it looked at discussion partners for pregnant people for who did they talk about their decision to get a Tdap, a flu, and a COVID-19 vaccine during pregnancy. And the top person was their prenatal care provider each time. Additionally, we know that this slide is showing ranking the top 3 reasons for getting a flu, Tdap, or COVID-19 during pregnancy. And once again, my healthcare provider recommended it was the top reason for each vaccine. So we know that that strong recommendation is extremely important and that people are listening. So how to have that conversation and how to give that strong recommendation. There are a lot of different frameworks, and I think the more conversations you have, the more comfortable you get answering questions and starting the conversation. I know, probably a lot of us have had more, vaccine conversations, in the last few years, with COVID-19. So here's just one framework that you can look to. All of them, I feel like, kind of have some of the same themes. So this one is the recommend, ask, acknowledge, and advise. So that recommendation, could look like, we're going to measure your belly today and do the Tdap and flu vaccines along with your RhoGAM. The Tdap is going to prevent your or protect your baby from whooping cough after they're born, and the flu vaccine protects you and the baby. Do you have any questions about the plan today? So letting them know, what is due, asking that open-ended question to elicit any, to find out if there's any questions or hesitancy, but it, does present vaccines as the standard of care. And then the acknowledge piece is, if they are A-okay with the plan, support the decision to follow the schedule. And then if they are hesitant, or have questions, I think that it's important to be, empathetic. It's important to listen. It's important to acknowledge that, they have, real concerns, and it's great that they're asking questions about their health and, want to know more about what's going on. So I think at this time, kind of really, being that active listener and being a supportive listener is an important piece of acknowledging. And then in the advice piece, the focus really is tailoring your advice to the patient's specific questions. So again, not assuming why, somebody might, not want to receive a vaccine, but actually asking them, specifically, and trying to advise them, and that doesn't have to be, that's generally not throwing all of the data at them. If they ask for data, great. But a lot of times, these decisions are more emotional decisions. And so I think remembering that is really important. And, even advising, if when I was pregnant, I received these vaccines, or, anything you can do to kind of, connect with that person. And you do want to end on one action that you agree on. So even if they decide not to get a vaccine, that could be like, hey, I'm going to send you home with some information. Do you think you could look at it before our next appointment? So, something like that. And again, there's a lot of different frameworks. There's motivational interviewing frameworks, different acronyms. So just kind of finding the structure that, works for you and your patients. And then also what I want to touch on is, during pregnancy, a lot of people do, make decisions on, after the baby is born. So I think it is important to talk about, vaccines in a way that like, yep, there's vaccines that are due now, but there's also, going to be vaccine decisions after your baby is born. And that includes, the birth dose of Hep B to, their future doses in their childhood. And so I think it's important to share accurate information and reliable sources on childhood vaccines, so that they are equipped to make an informed decision, and that they, that they're able to identify what a good, resource is. And that can be hard, especially with, there's a lot of social media and a lot of, you can find a lot of different things on the internet, and not all of it is accurate. And again, the strong provider, or the strong recommendation from a provider is extremely important for, vaccines during pregnancy, as well as vaccines in childhood. So if you want some resources for patients to, send home with them or refer to them, I did include this in this slide with links with information during pregnancy, and some of them touch on after the baby is born as well. I think we are going to do questions at the end of the presentation. So I will go ahead and stop sharing my screen and hand it off to Christine.
Christine, we can't hear you.
Oh, yeah, you're muted, Christine.
I did hear the off.
Okay. I might call in, try it.
Okay.
I feel like it comes in and out. So it's working now, I think.
Yes,
Yeah.
it is.
Okay, so I'm just gonna leave that and pray that it keeps working. And we'll go from there. So like Shalia said, my name is Christine Rohali. I am program coordinator for the Mary Bridge Immunization Clinic in Tacoma. That is a clinic that solely does immunizations for children who are in need, whether that's because their families don't have access to medical care, they can't afford that medical care, they just moved to the area and don't have a provider set up. We see a lot of refugees and immigrants at this clinic, and we do thousands of vaccines on an annual basis. And I am going to talk about vaccines in early childhood, as well as kind of having those critical conversations with families. And give me a second to see if I can figure out how to share my screen again. Okay.
Looks good.
Okay, sweet. So I went over all that. So a couple things I'm going to go over, what are vaccines and why do we do them? What vaccines do we do in early childhood? I know the presentation's up to a year. I'm going to kind of do 18 months, just because there is kind of like a 12 to 15 month kind of time frame for kids. What are some common vaccine concerns that families might bring up to you? Understanding the history behind those concerns, as well as how to address them, and then kind of what is our role as providers And that's all providers. It doesn't matter if you're a nurse, a doctor, someone who can give vaccines, any provider that has contact with a pregnant person or a parent of a child does have a responsibility and can be a trusted source on vaccinations for that family. So I'm gonna kind of go into vaccines 101. So what are vaccines? Okay, we know that they're medications or drugs that teach your body how to fight off diseases. There's a ton of different types of vaccines. I know in the media, it kind of sounds like there's regular vaccines and then there's mRNA. That's kind of how it feels lately. But there's actually a whole bunch of different kinds of vaccines. So we have our inactivated vaccines. Those are ones that use dead versions of the germ. We have our live attenuated, so like your MMRs and your varicellas. Those use attenuated or a weakened version of a germ. So it's not strong enough to cause you to actually get the disease, but it does promote an immune response. You have your mRNA vaccines, which we all know about from COVID vaccinations. So those basically take like a recipe, if you will, and they deliver it to your body and they teach your body how to make a portion of that disease. So it's not a portion of the disease that can make you sick, but it's a portion that can then mount an immune response within your body so that your body then develops the appropriate antibodies. You have your subunit vaccines, which again use specific pieces of the germs that trigger an immune response without actually causing the disease because they aren't the entire disease or the entire germ itself. Toxoid, same thing, it just uses a different part of the germ. And then we have our viral vector, which we also hear about for COVID vaccines. That one is the technology that the Novavax vaccine for adults is built off of. It's similar to the mRNA in that it delivers kind of that recipe to your body, but the way it delivers it is by using a weakened version of another germ, which is where you get the viral and then the vector, so delivery system. So it just kind of uses another disease as a carrier to take that recipe to the right spot of your body. Your fun fact for this slide is that COVID vaccines are not actually the first mRNA vaccines that were ever developed. So that is a misconception that you will hear a lot, that mRNA was brand new technology. We came up with it too fast, and that's why you should be skeptical of it. We've actually used mRNA for vaccinations before, just not as widely. We first utilized it for Ebola vaccinations actually in 2016. So it is, you can say with confidence, it is a tried and true and tested vaccination technology. We have a couple different methods of delivery for vaccines. So the most common, of course, is injections. Oral vaccinations, those are pretty much only used in the US for children for rotavirus vaccination for young infants. Other countries may use oral vaccines more widely for things like polio, but you won't see that within the United States. And then we have nasal sprays. We think of that most commonly with our live flu vaccine. Nasal sprays are not commonly used for infants and young children. Nasal flu vaccines are only approved for kids over the age of 2. So why should we vaccinate? I think we all know many of the reasons. Vaccines save lives. They prevent serious harm in yourself. Getting the disease can cause lifelong complications. Getting meningitis can cause brain damage. It can cause seizures. It can cause death. You can lose limbs. You can end up with respiratory or cardiac problems. For example, if you get infected with polio. Lots of reasons to vaccinate. A lot of people tend to kind of focus on what I'm going to call here the greater good fallacies. So those are things we think of when we say like why you should vaccinate. Like it'll protect the people around you. It's the right thing to do. But I think what a lot of people don't always understand is that humans aren't often swayed by things like that. We all like to think we're really good people, and we are. But a lot of people are really honestly inherently selfish. And when you say like vaccinate your child so that the kid with cancer in your child's school doesn't get sick from the measles, like arguments like that very rarely work on people. It really only tends to work if it's like a personal reason. So, the child lives with the grandparent who's sick, and then the people can actually make that direct connection of like this person that I love and care about could be adversely affected by it. It's a really hard thing to conceptualize when you tell people that like the greater population will benefit from their child being vaccinated. And it's just not an argument that really tends to work on people. So I kind of suggest, shy away from that unless there's a personal story that actually, is relevant for that client. Otherwise, I usually recommend focusing on, like what are the direct effects to like that child or that parent. Make it a personal decision for them. And then below, vaccination, again, is ultimately a personal decision. Everyone's going to have their own feelings. Everyone's going to have their own reasoning. They may pick different decisions for one child than they did with another. We saw that a lot during the pandemic. We had families that were historically trustful. They trusted medical care. They vaccinated their children. And I've had many families express to me that, because of the misinformation surrounding the development and the speed of the development of the COVID vaccinations, it made them question vaccine science, unfortunately, as a whole. And it made them kind of take a step back and think, did I do the right thing by vaccinating my other kids? And this is not a situation where their other children necessarily suffered harm from those vaccines. They're just taking a step back and saying, maybe I didn't evaluate this situation all the way in the beginning, and maybe I didn't make the right choice. And now they're not vaccinating their future children. And that's a really interesting thing that's been brought about by the pandemic, is that we've seen people who we never thought to have those conversations with, who are now questioning medical care. And that's a difficult thing to address with people, because they don't necessarily have a specific concern, like this vaccine will cause my child to be autistic. And that's something you can discuss directly. It's kind of more just a general feeling of not being sure about things. And parents may not agree with one another. You may have one parent who is pro-vaccination and the other parent who isn't. And how do you navigate those conversations? And you really need to kind of just be a third party and kind of just a safe and trusted source. The most important thing you can do is be a safe source where that family feels like they can tell you their beliefs. They don't want to be shamed. They don't want to be judged. No matter how ridiculous you might find their reasoning or their misinformation, it's important that they feel safe sharing that with you, because if they don't tell you, you can't have that conversation where you can move forward with how do we address this and where do we go from here. Kind of just went over this, but this conversation really should be done by everyone. So even if you're not a provider who has the ability to order, to prescribe, to administer vaccinations, if you are someone caring for a child in a medical capacity or a pregnant person, you should really be starting this conversation early. The earlier you identify that they may have questions about vaccines or they may be unsure about them, the more time you have before that child is born to address those problems, to discuss them, and to open that conversation. You would ask a pregnant person whether they plan to breastfeed versus formula feed, so that you know how to support them, so that you know how to get the resources that they might need. And you should do the same with vaccines. Again, it's not about shaming them for their decision. It's about identifying their decision and deciding where do we go from here. Especially because, like Kate said, nowadays in social media, misinformation is everywhere. If you go on Facebook, you go to the CDC's page, click the comments on any post. It doesn't even matter if the post is about vaccines, and you'll see hundreds of comments just spreading vaccine misinformation, spreading false images, saying that the CDC is out to, kill your family and kill your children. And imagine if you're a parent who's, like most of us, is on social media on the daily, and that you are getting that constant exposure. And even if it's not something that you necessarily believe, the more that you see something like that, the more it sits in the back of your mind. And then when that conversation does come up, that kind of floats to the front of our brains. And we're like, well, we never thought of ourselves as someone who might not trust science, but I remember reading that online. And how do I know that that wasn't true, that that person's experience didn't really happen to them? So, what vaccines do we give in early childhood? Quite a few. This list would probably look really overwhelming to a parent, but again, that's why we have these conversations. So, at birth, child's typically receiving their hepatitis B vaccine, and we do now have the new RSV medication, like Kate touched on a little bit. RSV vaccine, it's technically not a vaccination for the infants. It's technically a monoclonal antibody. but for the purposes of administration and ordering, we are treating it like a vaccine. So it is being added to the childhood vaccine recommendation schedule. A child can receive it at birth as long as the mother did not receive it during pregnancy, or if the baby was delivered within 2 weeks of the mother receiving the vaccine, as it hadn't had time to take full effect. Children who are already born, now that that vaccine is approved and don't have the opportunity to receive it at birth, they can receive it up until 8 months of age or through their first RSV season. Children who are 2, 4, and 6 months will receive their first DTaps, polio vaccines, hepatitis B's, HIV, which is similar to meningitis, it stands for Haemophilus influenzae type B, don't make me pronounce that again. And then your rotavirus vaccination, as well as your pneumococcal vaccine. Once they reach age 12 to 15 months, they'll get a booster of the DTaP, the HIV, and the PCV. They will also start their MMR and varicella series, and they will also start their hepatitis A series. I did give this one a little star here just because they will get the second dose around 18 months of age, assuming they started it at 12 months, whereas these other vaccines on the list are either finished or they won't get boosters until they are school aged. And then we have our annual vaccines. So like Kate said, flu vaccinations can start as young as 6 months of age. It is a 2-dose initial series for infants, which a lot of people don't realize. So that first dose just kind of introduces the vaccine to the immune system. And then the second one actually builds that immunity. After that, they follow a once-a-year schedule like adults do. COVID-19, similar concept. For Moderna, it's a 2-dose initial series, and then we are transitioning to an annual approach. Pfizer is a 3-dose initial series. I did put some stars under 2, 4, and 6 months next to the HIV and the rotavirus. HIV because it can be a 3 or a 4-dose series dependent on the brand that is used. Rotavirus, 2 or 3 doses, again, depending on the brand. So what does that come out to? Individually, if a parent chooses to not utilize combination vaccines and get individual pokes for everything, that can be upwards of 28 injections and 3 oral vaccines in the first 18 months of life. That number is the high end, so that's presuming a 4-dose HIV series, a full 2-dose flu, a full 3-dose Pfizer. If parents utilize combination vaccines, which I strongly recommend in all situations, it's as few as 18 or 19 individual injections, and then again, the 3 oral vaccinations. One question that might come up is like, why do we do these ages? You know, why do kids get hepatitis B at birth, but they don't get the chickenpox vaccine until they're 1? A lot of that has to do with the individual science on how those antibodies, how long those antibodies last in the baby after birth. So they've done a lot of research, of course, and different diseases, the antibody levels stay on after birth, again, presuming the mother had adequate antibody levels and was vaccinated against these diseases. They found things like the live vaccine, so the MMR and the varicella, don't really start to wear off until the age of 1, which is why we wait until then to vaccinate. Whereas other things, they really don't have high antibody levels right away, so we start vaccinating them right away. One thing you will see is that a question that does come up often in my clinic, hepatitis B. It can be a very controversial thing at birth. I imagine the RSV vaccine is going to start the same way. And people are just really, a lot of people can be really hesitant about giving a baby that was just born an hour ago a vaccination. They're afraid that it might be too much on them, that the baby's system is already overwhelmed from birth. You know, how could my baby possibly need a vaccine? They just came out of me 30 minutes ago. Where are they going to get exposed to hepatitis B? And that's not a wrong fear to have. Really, the reason we vaccinate and most countries vaccinate against hepatitis B at birth is because we found that that was the best way to prevent community hepatitis B levels and overall transmission. When we first came out with that vaccine, we did try only vaccinating the at-risk populations, so intravenous drug users, men who have sex with men, because hepatitis B is transmitted via bodily fluids. And they found that just vaccinating the at-risk population was really not reducing community transmission of that disease, in part because those populations either weren't self-identifying as at-risk or were not coming in for medical care. And we found that when we started universally vaccinating at birth, that it significantly decreased those community levels of hepatitis B and prevented children from getting it later on in life. Unfortunately, in America, we also don't have high levels of consistent prenatal care. So while mothers are screened for hepatitis B during pregnancy to identify if that child is at risk, it's just not a wide practice, and we don't have universal medical sharing systems across states. So if families move, it may be difficult to identify whether or not that screening has been done. Some anti-vax people will point to what Canada does for hepatitis B, which is that they don't actually vaccinate for that until kids are in middle school, about 8th grade. And the reason for that is that they have higher rates of prenatal care, and they have, I believe, a countrywide medical sharing network. So it's really easy for them to identify that the mother was screened for it in one province and then moved to another. And they have not found that they need to lower that age in order to reduce the community transmission levels. Some people will be concerned about the number of vaccines that you're giving a child. So particularly at the age of 12 to 15 months, the 2 to 4 and 6 month vaccines can pretty much all be done as one injection with the use of combination vaccines. But unfortunately, when you reach the age of 12 to 15 months, they do mostly have to be done individual. And that can raise some concerns for families because your child went from getting 2 pokes every 2 months to now you're telling them they need maybe 5 shots in a visit. And if it's flu season, they might need 7 if you add on flu and COVID. And that can sound very overwhelming, rightly so, to a parent. Usually I talk to them about it, that it's actually the same number in general of diseases being presented against. It just comes in more pokes. So you're really not taxing the child's immune system anymore in terms of like the sheer number of diseases you are vaccinating against. It just unfortunately comes in a delivery system that's more individual. Parents may still choose to split that up. A lot of families with their little babies, they don't want them to get poked 5 to 7 times in one visit. And that's a compromise that is acceptable. I mean, if the choice is vaccinate them over 2 visits versus don't do it at all, split it up. This is kind of the CDC's infographic. They carry this on their website in English and Spanish. So that's what I was using to do the math in the other slide. And it just kind of shows, this one goes up to kindergarten school age, and it shows the vaccines that are required at each age. In general, recommend the vaccine as early as possible to increase the odds that the child receives it. If you choose to delay a vaccine when it's available and when it can be given, it increases the risk that the child will not come back to finish that series within an appropriate time frame. So what are some common vaccine concerns? There's a lot of them. I don't have all day, so I'm going to go through the most common ones I heard. But most concerns are rooted in personal experiences. So a parent has an autistic child, and now they're concerned, you know, based on the information that's online and based on their personal experience, that the vaccines could cause their other children to become autistic as well. Some people were not vaccinated themselves as children, and that, you know, information has persisted to present day. You know, they say, I wasn't vaccinated and I'm fine. Therefore, why would I vaccinate my child? Some people have had a personal negative reaction to a vaccine, or they've witnessed someone have a perceived, you know, allergic reaction or adverse effect to a vaccine. It's not always accurate. That's not always what happened. But if that's an experience that they had, that might be why they're then hesitant to vaccinate. Sometimes it's a trusted family member or a friend or even their spouse who has said, you know, hey, no, vaccines are bad. We shouldn't do this. And when that comes from someone you trust and someone you love, that can be a difficult thing to overcome. So we're going to go through some of the common ones. So one thing you might hear is the use of fetal cells in vaccinations. So that can be a concern for persons who are anti-abortion and believe that by utilizing fetal cells, you are therefore supporting the practice of abortion because that is how those cells were obtained. Some facts on that: all major religious leaders have permitted the use of such vaccines when alternatives are unavailable. So the Pope has come out and said, you know, if you do not have an alternative vaccination science, we do believe that this is acceptable under the premise of our religion. The cells that we utilize to create these vaccines were obtained in the 1960s. We don't continually harvest fetal cells to use in vaccination production. We just regrow the original cells from the 1960s. So there is no continued practice of aborting babies or harvesting aborted fetuses or aborted fetal tissue. There is no buy-sell agreement between Planned Parenthood and Big Pharma where they harvest this fetal tissue to continue with their vaccine production. That is not true. The cells are actually just used to grow the viruses. They're like a host. There are actually no cells within the vaccinations themselves. So there is no fetal tissue that is actually being injected into your body. There is no fetal DNA that can interact with your body. The only vaccines that this is a concern for are varicella, rubella, and hepatitis A. I put a little star against rubella because you're going to see that in the sense of the MMR vaccine. There is no rubella only vaccine. I have seen parents come in and ask for, can I just have the measles? Can I just have the mumps? Because we don't want that rubella component. And unfortunately, that is not an option within the United States, although it may be an option in some other countries. I'm not going to pronounce this next word because I have no idea how to pronounce it. So we're going to call it mercury from here on out. You might hear a concern about mercury in vaccines. We all know mercury is bad. You don't want to ingest it. It was actually removed from all childhood vaccines by the year 2001. That information still does persist online. I have had parents come to me and say, hey, I don't want these vaccines because they contain mercury. This one's very simple. It's not in vaccines. It's not a concern. You don't have to go further into why it was removed, whether or not it was safe. It's just not in vaccines. That's an easy one. Some flu vaccines that get produced in multi-dose vials will still contain it as a preservative, but that's only multi-dose vials. Typically, most places will use single-dose flu vaccines. I personally have not seen multi-dose vials widely used in pediatric vaccination, but if that comes up, that is the only vaccine where that could potentially be a concern. Aluminum. This is one that actually comes up pretty often for me. People are concerned about the aluminum levels in vaccination. The concern is that the amount of aluminum builds up in the bloodstream and can cause brain damage later on in life. There was also a recent study that purported to show a link between childhood asthma development and aluminum. This one's still up for debate. Simple fact for you, infants are actually exposed to more aluminum via their food, breast milk, or formula than via vaccines over the same period of time. So they'll receive about 4.4 milligrams of aluminum in the first 6 months of life via vaccination. Breastfed infants will receive about 7 milligrams just from breast milk alone. Standard formula feds about 38 milligrams, and soy formula is over 100 milligrams. And that's just from the food that they eat and have to eat every day. You will hear parents that may request specific brands of vaccines that have lower aluminum than other brands, or they may space out the vaccines in order to decrease the amount of exposure that the child receives at a single time. They want to give the child enough time to process the aluminum from their system before adding more. In the end, aluminum is not really a concern. They've done a lot of studies on it. Your body knows how to excrete these products. So unless the child has significant kidney damage and they're unable to properly process ingredients like that, it's really not a concern. And the amount of aluminum that vaccines contain is so low that it's really not a concern anyway. The concern for people with kidney damage is mostly like premature infants who are on continuous IV fluids, which contain a high level of additives such as aluminum that are going directly into the bloodstream, or TPN, which is IV nutrition for kids who can't eat by mouth. Those kids are definitely at risk for the aluminum buildup and then eventual brain damage. It's really not related to vaccinations. Big one, of course, MMR and autism. So how did this one come about? There were 2 studies that were done, one in 1998 and one in 2002. They claimed to show a link between the 1-year-old vaccinations which then got associated with the MMR specifically, and then the later development of autism. Both studies were done by the same people. The journals that published them have since retracted those studies and said, we don't stand by this anymore. These are false. The author of those studies has lost his medical license, but is unfortunately a very outspoken person in the anti-vax community, and continues to stand by his studies. And unfortunately is pushing the idea that, the pharmaceutical companies, big pharma, has silenced him, for his work. There have since been dozens of studies that have basically said this is false. There is no link. But as we know, data is not always something that can sway people. So if parents are unconvinced by that data, one thing that you can do is kind of find a middle ground. So kids are generally found to be autistic between the ages of 12 to 24 months. And that's because that's when they develop the motor skills that are most heavily affected by autism. So we kind of see that correlation where the MMR vaccine gets done at 12 months. Well, that's when the signs and symptoms become most prevalent. So it results in confirmation bias. It's really hard to say to someone like, just because you got this vaccine at 12 months and then you notice your child was autistic does not mean they're related, because that can be a very powerful thing. They witnessed their child getting vaccines, and then they witnessed their child maybe losing the ability to speak, losing the ability to walk, no longer making eye contact. And that's a really powerful experience for a parent. And as a provider, you can't just go in and say, you're wrong, it's not what you think, because right then you're going to lose all the trust that that person has in you. So one thing that I can recommend then, if they really have that very powerful, experience, or they really cannot just be swayed by data or, other explanations, defer the MMR vaccine until that child is out of the risk window, if you will, for autism. So age 2 years, for example. Older children do not become autistic overnight. Autism is something that people are born with, and sometimes the symptoms can appear very, very early on in infancy, depending on how they present and how severe the child's autism is. Other times it takes a little longer, but if you wait till about 2 years, if you want to call it a risk window for autism, the child is out of that. You don't have 2-year-olds that wake up and are suddenly autistic overnight. So kind of you can work with that middle ground. You can say, okay, I understand that this is how you feel about this. I understand that this is a serious concern you have. Let's wait until the period where you are confident that your child is no longer at risk for that. And then let's go ahead and vaccinate at that time. In Pacific Islanders specifically, they may have a different type of distrust in the MMR vaccine. So in 2018, I believe it was in Samoa, 2 infants actually died within hours of receiving MMR vaccines because they were improperly reconstituted. So typically MMR is a powder that is reconstituted using sterile water. These 2 MMR vaccines were unfortunately reconstituted with muscle relaxants instead, and it caused almost immediate death in these 2 infants, which spread a severe mistrust of not only medical care, but vaccinations in general, as well as specific fear of the MMR vaccine in Samoa and the surrounding Pacific Islands. So you will sometimes see that in parents that have relocated from those communities, that there is a very strong distrust in nurses or vaccinations, unfortunately, due to that incident. So what are your roles as providers? So the big thing is just keep the conversation open. You do not have to agree with someone's beliefs. You do not have to understand their beliefs. You do not have to encourage their beliefs. But it's important that you are a trusted person that they can come talk to, and they feel like they can be honest to about that. Because if you don't know why they're afraid of vaccines, you can't do anything about it. That does not mean you have to compromise your own beliefs to support that client, okay? You are not responsible for signing religious exemptions under state law if you are not comfortable with that, assuming you're a provider who is legally allowed to. If you're not comfortable with that, you don't have to do that. You are not responsible for inventing alternate vaccination schedules for people. You're not responsible for special ordering specific vaccine brands because a parent believes one is better than the other. You're not responsible for bending over backwards to rearrange your clinic schedule to provide weekly appointments because they want one vaccine a week. I know that sounds mean, but there's a way to support them without bending over backwards for them. You know, at my clinic, I try and be as accommodating within reason. So I'm not going to special order a single dose of a vaccine just because they believe that that's better for their child. You know, that's not to say that that's not the vaccine they should have, just that's not something that I am able to give to them. I encourage families to come up with their own alternate vaccination schedule if that's something that they're interested in. If you start creating those schedules for them, it can kind of seem like that's the schedule that you recommend. So I really just leave it as, you know, do you have a plan for vaccines or do you want to talk about your options and let them go from there? It's really important to treat them with respect, thank them for trusting you with that information, acknowledge that that's what they believe, even if that's not what you believe. You can say, I understand that is how you feel. You know, thank you for sharing that with me. And understand that you may not change everybody's mind. Some people may go on an alternate vaccination schedule for the entirety of the child's life. I don't treat it as an all or nothing approach. Some vaccines are better as no vaccines. I think if a parent comes in once a week for one vaccine at a time, to me, that's a win. It may not feel like a win because you're not changing their mind, but that child is getting vaccinated. And if they don't trust you as a source, or they don't trust their primary care provider, they may stop receiving vaccines at all because they don't feel like they're respected in their decisions when they go into a practice. They might not feel like they're supported. And that's dangerous because one vaccine is better than none. And I always try to encourage parents, you know, if you did one at the last visit and you felt like your child tolerated it well, maybe let's try adding another one today and go for two. They may not go for it. They might. Again, anything that you can get should be considered a win. Just support them any way that you can. Educate them with their consent. So don't lecture them. Don't throw data on them that they're not open to hearing. Okay. And again, provide the immunizations within your best ability and within reason. This is my last slide. I just want to shout out some resources. You don't have to know the answers to everything. People come in here all the time and bring up concerns about vaccines that I've never heard of. And I say, okay, let's look that up and let's figure out where to go. I love the Children's Hospital of Philadelphia website. I think that went over. It basically answers every question that your family might have about vaccines. You can go down to ingredients. You can learn about aluminum in vaccines. You can download a parent-friendly handout in different languages. They can watch videos. They can learn the exact amount of aluminum that's in vaccines. It's a phenomenal website in my experience for going over pretty much any concern a parent might have. And it's very family friendly where they can go on themselves and learn different information. That's usually my go-to. Immunize.org has a lot of good handouts on vaccinations. And then of course the Centers for Disease Control, but this one may often be a less trustworthy source by some families in today's day and age. That is all I have for you guys. I thought I had one. There we go. That is my contact information if you guys need it. I assume they'll also send it out at the end of the presentation, but feel free to reach out to me with any questions.
Thank you so much. That was wonderful. So many good points, and I really like the discussion on how to communicate with families and parents when discussing immunizations. Obviously, that's very important. Let me check if there are any questions so far. It doesn't look like it. I did put in the chat box that, and I'll say it now, if anyone has any questions, I'll go ahead and give just a minute or two. If you guys have questions, to go ahead and put them in that Q&A box. So give y'all just a minute. while we're waiting, Christine, I have a question. You talked about alternative vaccine schedules, and I have heard parents and families mention this. Other than, I guess, what is the benefit of families choosing that? Is it primarily just to reduce the exposure all at once, or what are some other things that you have, I guess, heard in regards to that? Oh, you're on mute. Sorry.
There we go. No,
There we go. Oh, I think you're on mute again.
I think your sound is cutting out.
Yeah. It's like I can hear you now. Oh, and then it just went out again. It might be helpful too, Christine, if you turn your video off and see if that helps with the audio. Because sometimes there's not enough for it to do all those. I think I might have heard you.
Well, Christine, maybe while you're calling in, I can share from my experience why
Wonderful.
alternative vaccine schedules are of interest to some families. And that would, some of it is not wanting to get all of, the injections on the same day at the same time. Sometimes people feel like it is overwhelming the immune system, getting too many vaccines at once. Those are two kind of the more common things that I hear. And then, like Christine had mentioned throughout her presentation, some people have issues with particular vaccines over, something like fetal cells, or hearing a story from, a friend about a particular vaccine. So they might be opting not to get that one. And so I'm not sure, Christine will probably have stuff to add, but I think it's also important to note kind of why the schedule is the way it is. And one, it's been studied in its, recommended iteration. So, the safety and efficacy has been studied at that time. Not saying that alternative schedules are inherently unsafe or not effective, but we also know that the vaccines are given at particular times because you're potentially going to be more exposed or have a more serious, serious complications from an infection. So like Christine mentioned, the Hib vaccine, that's just given to babies. And that's because it really only affects babies. So if, you can age like out of that vaccine or the rotavirus vaccine, because we know that these illnesses, affect them more severely. So it is important to get them on time. And like I mentioned with the DTaP or the pertussis vaccine, getting it at 2 months as early as you can is important, because whooping cough is really dangerous for babies. And, that even if the pregnant person got the Tdap during pregnancy, that, immunity, that passive immunity isn't as hardy as making your own antibodies. So it is going to fade, but it does protect during that window before they can get their own vaccines. Some other.
My phone, can you hear me?
Oh, yeah. You are on. And then I was just going to mention, I know that there was a book by, a Dr. Sears that has been a popular alternative schedule. So people might refer to that alternative schedule as well. Christine?
Yeah, I think Kate covered most of it. Like I said, you have to understand why they're choosing that schedule. In the case of a parent who's concerned about aluminum buildup, they want to reduce the amount of aluminum that their child receives, in any given instance, and give their child time to process or clear most of that out of their body before they receive more. In Eastern European families, that in my experience, so people who have immigrated here from Russia or the Ukraine, I find a lot of times they're not comfortable doing more than 1 or 2 vaccines at a time because that's how vaccines are done out there. You don't go into an office and have 5 vaccines at once. So that's an uncomfortable experience for them because that's not what they are used to. And part of that is because they vaccinate against fewer diseases out there on the regular. So that is why children typically receive fewer vaccines in one visit. And most of those families, in my experience, are open to vaccination. They just want to limit the number at once. So I have some Ukrainian refugees who come in on a weekly basis just for 1 or 2 vaccines because that's what they're comfortable with. And in some situations, you have to evaluate, is it worth trying to change their mind on this if the end goal is being accomplished still? I've heard a lot of reasons for alternate schedules. Like Kate said, I think overwhelming the immune system is a big one. Kids do actually encounter far more overwhelming things to their immune system on a daily basis via just the bazillions of germs that are in our environment. But sometimes this can just, because you can see it, it feels more direct. You can tell people you touch 1 million germs a day. But you can't see that, and you can't see that your immune system is working on that. So that's a hard thing to conceptualize compared to your child got an injection and now they're cranky and they have a fever because their immune system is working.
Great, thank you. We do have a comment in the box that says, sorry guys, excuse me. I mentioned earlier, I'm getting over a cold, so my voice is kind of a little shaky. We had a comment that said some of the parents, excuse me, in our clinic just don't want to give that many shots in one visit to their child, typically because the child has a bad reaction to needles. I'm not sure if this just means they're scared of needles, would maybe be my guess. But that was just a comment that was in the chat box.
That's definitely something I see often. Again, you kind of have to toe that line between, encouraging more, but also like respecting that they have a genuine concern over that. I have seen people who don't vaccinate as infants, and then they try to enroll their child in public school, and all of a sudden they need all these vaccines, and you have 5-year-olds that are absolutely terrified now, like so much medical trauma because they are now getting constant injections at an age where they have a really heightened fear of them, and the world is overwhelming at that age, and they have to be held down. Honestly, if you do them when they're infants, they don't, does it cause pain? Yes. Do they remember that? No. And even though it can be traumatizing, to watch your little tiny baby have a needle put in them, that's hard for a parent. It's better in the long run. Again, sometimes you're not going to convince them. If they don't want to do 6 shots in a visit, split it up. It's better to split it up than to have them say, then I'm not doing anything. You kind of have to find that middle ground to how can we accomplish this. It is recommended to have all vaccines that are available and eligible at a visit be done at that visit, because if you do delay them, the odds that that child then misses those vaccines increases exponentially, because you can say, come back in 2 weeks. Will they come back in 2 weeks? What if they come back in 2 weeks and your refrigerator has broken and now you don't have vaccines and now they don't have an option? I've seen that a lot. It's really best practice to give everything available, assuming the parents are on board with it at that one time, because you may lose that opportunity. They may move to another state and now they can't set up a pediatrician for 6 months because everyone is short-staffed or everyone is not taking new patients. And now their child can't go to school because they didn't get the vaccines they were eligible for at a visit where they had the opportunity to get them. So there's really no benefit, I guess is what I'm saying, to not do vaccines at a visit if you have them. But it's also not worth it to fight a parent on that if that is a strongly held belief for them, if that makes sense.
No, that does. Thank you.
And I will add that there are some products that Christine maybe can share how well some of these work, but I know that there are some products that you can try, at your clinic, or, families could bring in like a shot blocker, which is like this little plastic thing that has kind of multiple, like, not neat, like blunt points on it, and you put it on the arm and then give the shot, and it kind of distracts your nerve endings from feeling, called Buzzy the Bee, that like vibrates and does the same type of a thing. And I know there are some kind of cooling sprays that could be used. So for kids that do have a lot of fear, those might be helpful, or just, trying something new might also be helpful.
Great, thank you. I don't see any more questions in the chat box. Excuse me. That was a wonderful presentation. Thank you both so much. We are very appreciative of that.
Thanks for having us.
Yes, thank you.
Yeah, thank you so much.
All right. Give me just a moment to pull up our next slide here. Just a moment.
So this is Heather with the Healthcare Authority. I wanted to let you guys know, hot off the presses, a Healthcare Authority update. This flyer here that Shalia is sharing is something that I believe we just started sharing as of yesterday. So you guys are kind of one of the first to know. So the Healthcare Authority has been working with the Institute for Medicaid Innovation. We received a 3-year grant in regards to midwifery care, and we're working on trying to increase knowledge of midwifery care with the Apple Health Medicaid clients. And so there's this flyer here that has a QR code that clients can scan to take a survey. And this is for clients who are currently receiving their obstetric care through a midwife, or have recently received their care through a midwife. And the survey is in, I believe, 6 languages. And clients are maybe eligible to receive a $50 Amazon gift card. I believe it's through a drawing. So anyone who takes the survey, at the end, they can enter their email address if they're interested in being put into the drawing for a $50 Amazon gift card. The survey is confidential, so the results wouldn't be attached to the email that's submitted. And it takes just about 5 minutes. So in a week or two, when we share the recording of this webinar, we'll include this flyer. There's a colored version that Shalia has posted here, and then we'll also send a black and white version. So if you have any clients who may be interested in doing the survey, because they're receiving services through a midwife, that would be great. We did survey the midwives, I believe it was last month. And so now it's the time that we're working on getting some information specifically from our Apple Health Medicaid clients. And if you have any questions, you can always email me, Heather Wire, at hca.wa.gov. I think that's it for that part. So thank you, Shalia, for letting me.
Of course. I just saw a comment that said the QR code does not work on this flyer.
It worked yesterday. Let me see.
I just tried it, and it said you need to choose a plan to reactivate. So I'm not sure who made this flyer.
Yep, I will.
But we will check on that for you.
Yeah, yeah.
So thank you so much for letting us know that. That's always great to like check and make sure those things work. All right, so we are going to go through our program updates rather quickly here, since we are almost out of time. All right. So just as a reminder, we have resumed program monitoring, and this is a full comprehensive, excuse me, monitoring. And so we will be requesting all client records. And additionally, we will be reviewing records for staff who are community health workers and infant case managers to make sure that they meet the required qualifications. Again, ICM EPA, I do pull a quarterly report that looks at claims that use the ICM EPA. And what I do with this report is I just look to see if it was used appropriately or if it was used and it wasn't necessary. But I also look at claims that were billed before the infant was eligible. So just a quick blurb about the EPA. It should only be used when the infant meets all of the following criteria. So they meet all of the ICM eligibility. The infant's eligibility for ICM begins during the 2nd month of life, and I will attach the newborn calendar for everyone to look at as a reference. And then ICM services are provided during an infant's 2nd month of life. And again, if you have any questions about that, please reach out and we are happy to provide more information. And then I will turn it over to Heather for the last update for you.
Before I do the last update, a question came in regards to the survey I just spoke about, asking if it applies to certified nurse midwives who work in a shared care model. So if a client sees a midwife, but also sees a doctor in their clinic, yes, please have any clients that have seen a midwife once, sees a midwife exclusively, or if there's a care team, anyone who has received any services, we would definitely appreciate them completing the survey. And then last, I just want to quickly remind everyone of the covered services in MSS and ICM. There are 2 specific WACs, one specific for MSS, one for ICM, and then it's also listed in the MSS and ICM billing guide. As a reminder, if you look at what's covered, pregnancy test is not listed. Pregnancy tests are not allowed in MSS. In order to begin receiving MSS, the client needs to be pregnant, so they should already know that they're pregnant before receiving MSS, and they also need to be already covered under Apple Health. So helping someone to apply for Apple Health to then begin receiving MSS is not allowed through the MSS, so that needs to be done separately. Okay.
Sorry about that.
The Zoom quit. And then also, I just wanted to say with ICM, it is a targeted case management program only, and the Centers for Medicare and Medicaid have only allowed that it be a case management program. So education and brief counseling are not covered services through ICM.
Sorry, I don't know why it keeps doing that.
So just as a reminder that those services are not allowed. And then also quickly, I know we're out of time, but for MSS, mental health services, counseling sessions, mental health treatment is not allowed in MSS. We do allow brief counseling, but anyone who's needing something, mental health treatment and services need to be referred to a mental health provider. Only brief counseling that is what's allowed in MSS. So any questions? I know I see some coming in and we're out of time, so we will definitely add an FAQ, but really, really quick, not all sites are being monitored. Shirley and I, it takes us a while just to do one. So currently, I think in the next calendar year, we're currently working on one, and then in the next calendar year, I think we're looking at monitoring 1 to 2 more agencies. So if you haven't heard from us, then your agency wasn't chosen, and we will definitely reach out once we do decide who is up for monitoring next. And there's a question about nurse family partnership for first-time moms, and that's not a program through MSS, it's separate, but we can definitely in the FAQ include links to DCYF's NFP program.
Wonderful,
Nothing
thank
else.
you.
I was just gonna say, unfortunately, I can't put the survey in the chat because it's, I only have the QR code, and I will definitely work on getting that fixed, and we'll get that sent out here in a week or two.
Yes, once we get the QR code fixed, we will make sure that we email it out to everyone who's registered. And I believe that's all. We are out of time. So thank you for letting us take a few extra minutes. And again, we are very thankful that you all were able to join us today.